Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more. Today on the podcast, we are interviewing Dr. Pratish Tosh. He is a professor of medicine and infectious disease here at the Mayo Clinic, and will share with us everything you want to know as an ophthalmologist about infectious disease.
Welcome, Dr. Tosh.
Hey, thank you for having me.
Thanks for being here. This is great.
We've recently had you on a podcast talking about risk management, and there is plenty in the infectious disease world about that. As if listeners that didn't listen to the other one,
You gotta listen to that one. It's so good.
Thank you.
we're going to get narrow the scope for the ophthalmologists out there that I think we all want to be doing a good job managing infectious diseases of our patients or preventing them, and look at that part of your current practice as an infectious disease doctor. So thank you for being here in that regard. And just remind us, currently at the Mayo Clinic, you do all this risk management leadership. What is your work-life balance between risk management and ID?
So I'm still barely. Majority of my time is as a clinician in infectious diseases, a split between patients, infections in patients with cancer, infections in patients with critical illness, so ICU/ID, and then ambulatory infectious diseases. And that's still what I primarily do, even though perhaps on my downtime, most of my brain power is focused on risk management. But it still comes back to infectious diseases. I remember in medical school, I didn't think I really wanted to do infectious diseases in my first 2 years, because it's just like, there's just endless names of things, bacteria and fungi, and then they would change the name. And this is impossible. But then it was into my third year and fourth year, and then of course really into my eventually as a fellow, where I realized that there's this is very conceptual once you actually get your hands on it. There's three very basic concepts of infectious diseases. And I often get okay, I have this immunocompromised patient, so it could be anything. Except from my point of view, I don't even know what immunocompromised means anymore. Because and I'm sure if there's any immunologists or hematologists, they're about to laugh at how I think about the immune system. But I think about they're immunocompromised in what way and to what degree, right? So there's neutrophils, which help with bacteria and molds, but they're not that useful for viruses or even yeasts like Candida. And so understanding, what is their neutrophil function? And then there's humoral immunity, so antibodies, which are helpful for bacteria, extracellular viruses like influenza or SARS-CoV-2. But someone with bad antibodies, they're not prone to more CMV disease, right? And so that gets to the cellular immunity, which of course, whether it's because of medications we've given them or because of AIDS or lung transplantation, that does these intracellular viruses such as CMV or the herpes viruses, and then yeasts and dimorphics like histoplasma. And then I think about people without spleens, and then the encapsulated organisms such as strep pneumo being the big one, and then terminal complements, that's just Neisseria. And so I only think about the immune system in 5 ways, and I think about this patient, are they immunocompromised? In what way and to what degree? And then somebody with AIDS, and see if we're kind of 2, yes, they're going to get bad histoplasma and yeast infections, and maybe CMV disease, but they're not going to get invasive aspergillus. And somebody with neutropenia, really bad neutropenia, will get invasive aspergillus, but they're not going to get CMV disease unless they have problems with their cellular immunity. And so it's, instead of thinking this person is immunocompromised, they can have anything, that's not really true. Really understanding in what way are they immunocompromised, and frankly, what are the bugs that part of the immune system helps with? And then those are the things that could be causing it. So that was the concept number 1.
fascinating.
I appreciate that.
Yeah, I love that.
I didn't think about that. The second concept, my one of my mentors who subsequently passed away, Jim Steckelberg, still the smartest person I've ever worked with. I'm sure there are smarter people who have ever lived, right? But of all the people I've ever worked with, Jim was easily the smartest. What he was really good with was taking really complex ideas and making them very simple. And I remember he told me that the human body, he drew it, and it basically is it's a donut. The human body is a donut. And basically everything that's on the outside of the donut, which is your mouth is the top part of the hole and your rectum is the bottom part of the hole, but everything on the outside of the donut is part of the outside. And whether it's on your skin or in your small intestine or stomach, and it's okay that it has bugs in it, right? It's always going to have bugs in it. So the outside, as long as it's outside and the bugs are free flowing, is perfectly fine. And everything on the inside of the donut is sterile and is inside. So in ID, we only have two organs. It's either inside or outside. And let's say you have an abscess in your skin. Like, what happened was the outside became inside. And the treatment is making the inside outside again. You lance it. You don't need antibiotics, right? You make the inside outside. Same thing with the gallbladder, right? You get it. There are bugs.
This is highly amusing.
It's bugs in the that live there, right? And the gallbladder is part of the outside. It's part of the GI tract, part of the inside of the donut, right? But if you put a stone there, suddenly those bugs are no longer free flowing, right? So what happened was the outside became inside, and the treatment is making the inside outside again. It doesn't matter how do you do it. Do you blow through the stone? Do you put a percutaneous cholecystoscopy tube? It doesn't matter. Right? As long as if the outside became inside, make the inside outside again, and that's the treatment. The antibiotics maybe do anything, I'm not sure. And then the same thing with when the inside becomes outside, right? Let's say you have bone that gets exposed. If you just cut off the infected bone, well, now you have new infected bone, right? So you have to do a flap cover, right? So what happened was, the inside became outside, so you have to make the outside inside again. So 95% of ID is knowing whether it's supposed to be outside or inside.
Of the donut.
Right, of the donut.
Of the donut.
And if the outside became inside, make it outside again. If the inside became outside, make it inside again.
This is so amusing. I'm trying to decide if the eye is both inside and outside.
Yeah, that gets complicated.
We like to be special.
Right, of course. And is it sort of also immunologically a nice sanctuary?
Yes.
And so recognize
So we don't apply to any of your rules.
You do and you don't.
We're a little asterisks.
It's fine. But some of it around the eye. Right?
Yes, absolutely.
Right.
Yeah. I think the kind of most common times that we're really struggling with infectious diseases in ophthalmology, I was trying to kind of think, what are the biggest infections we deal with? I mean, the most simple are kind of corneal ulcers or outside infections, I would say. And we usually treat those topically with antibiotics. But a big part of our practice is culturing, seeing which bugs are growing, because sometimes they can be really bad bugs.
Yeah.
And sometimes we can treat them, if they're not that bad, with kind of simple broad spectrum things, but other times we treat them really kind of heavy hitting, compounded fortified antibiotics around the clock, really hard hitting. Is that all kind of correct from an infectious diseases standpoint? It's funny, sometimes I feel like some specialties treat certain things in one way, and then when you talk to the specialist, they're like, well, that's not how I would do it. And it's just because we're a little isolated in how we treat things.
Well, I like the use of topical antibiotics in ophthalmology because it's a sanctuary.
Yeah.
And by using things topically, you're far less likely to actually result in resistant organisms elsewhere. And this actually gets to the third concept of ID.
Oh, there's a third.
You transition very nicely.
Apologies.
No, it's fine. Because I think conceptually people think about antibiotic resistance there's a bug, and you throw all these antibiotics at it, and the bug becomes resistant. Mm-hmm. And that is true for rifampin and fluoroquinolones, and that's it. Antibiotic resistance developed eons ago. So the term antibiotic, everyone used the term antibiotic sort of vaguely, but the term antibiotic means it's a a compound in dilute concentration that can inhibit or kill a microorganism. But the piece of an antibiotic versus an antimicrobial is that that compound is derived from a living organism, right? So we get penicillin from penicillium, right? And streptomycin, not that anyone uses it, from Streptomyces. And in the eons that penicillin created that, not for our use, right, millions of years ago, but to kill off the bacteria in its path. So that was taking up its energy and its space. And in those eons, the bacteria created plasmids, integrons, pieces of DNA that encode the resistance to that. That didn't happen overnight. It happened over eons. And so antibiotic resistance very rarely is sort of de novo mutations. Instead, what you're doing is you are selected for clones of a bacteria that have existing resistance. They've gone into caves and swabbed them, and there's antibiotic resistance everywhere. No one's going into the cave and spraying vancomycin, right? So understanding how antibiotic resistance works, and it's not that you're creating it, but you're just selecting for the bugs
that already have it.
Got
it.
All right. And if I used to live in Atlanta, this will come to it. Imagine that airports were first come, first serve. Right. So your flights first come, first serve. Right. And every antibiotic resistance mechanism, like cassette of DNA or integron, is a suitcase or a backpack, right? If the flights are first come, first serve, and there's just passengers everywhere, if you're carrying around 5 suitcases, you're going to miss your flight, right? Whereas if you have a backpack, you're going to make that flight, right? And so it's not just how does that organism survive, but how does it outcompete the normal flora that's supposed to exist where it lives, right? So our skin has these bugs, our gut has, that's where most of it is, right? So antibiotic resistance isn't something necessarily we are creating, but rather the way that this 5 suitcase passenger is able to make their flight is if you get rid of all the other passengers, right? So why does it matter if I give azithromycin for a cold? How does that confer meropenem resistance? What it does is it knocks out the normal flora. It allows something that already has meropenem resistance to take
emerge.
hold, right?
I had no idea that's how it works. That's so interesting. Great analogy.
Thank you. And so so that's why I love topical antibiotics, right? Because there's most of the antibiotic resistance organisms, with the exception of MRSA, it colonizes the gut first, right? As long as you're not swallowing this, you're having almost no impact on the gut flora.
That's
so
super.
I love topical antibiotics.
So even though, when we give a topical antibiotic drop or a topical agent of whatever nature is, you can taste it in the back of your throat.
Yes, some get
There's
absorbed, but it's
some
probably
that's getting down.
tiny.
Okay.
Is that so negligible that your average doc doesn't need to worry about that, or is there enough little? I mean, this is with a regular drop.
Yeah.
They say, "Oh, doc, I can taste it in my throat,"
So small.
It might be there.
but it's not clinically
So-
important.
I doubt it.
Okay.
Yeah.
I doubt it. I love using gentamicin in bladder irrigations for people who have recurrent urinary tract infections who happen to be catheterized anyway, because that's the same thing. You get this really high concentration of this
Just
antibiotic,
focal.
and it's not impacting the gut. So you're sort of getting exactly where you need it without actually, selecting for bacteria that already have resistance.
Okay.
So in our patients who do need an oral antibiotic, so let's say they have orbital cellulitis or dacryocystitis, so an infected tear drain.
Thank you.
And you're welcome.
Oh yeah.
Yes, tear drains that get infected, lacrimal sacs that get infected, almost like an abscess, but they get a cellulitis type picture.
Sure.
Or someone who has even something more severe, like they've had an open globe injury, so they've had a penetrating injury to their eye that can predispose them for infection, or endophthalmitis, where they have an infection on the inside.
Yeah.
Bad stuff. And we want to treat them with an oral antibiotic. What I'm hearing is that the gut is so important. And I know everybody talks about probiotics. So immediately I thought, well, should I be giving my patients some kind of prophylactic probiotic situation?
So in the short term, the best thing to do is use the most narrow antibiotic you can for the shortest period of time that you need to.
Okay.
Right, that has the least impact on the gut flora. Unfortunately, probiotics haven't been shown to work yet, and there's a big yet, and I can explain this.
Okay.
So, the gut is 1,000 to 1 unculturable anaerobes for every 1 aerobe, right? And we're talking about 1 billion different bugs. And if you get something over the counter that's 1 bacteria, or even 10, it doesn't even come close to replicating the normal flora, right? And if sure enough, studies show that hasn't worked. And so there are more advanced probiotics that are actually in development. One has actually now been FDA approved for the use in C. diff. It's a pill that's essentially a fecal flora in a pill. And of course, right now it's just being used for C. diff, but that sort of advanced probiotic may be what we end up using in the future to sort of repopulate the normal flora. But we're not there yet, but very promising, and we're at a sort of a nice cusp in our technology where we actually have products that can do this right now that's not really available and not FDA approved for broader use, but it's something being investigated.
And I'm sorry. Well, so now you're saying just use the narrowest antibiotic for the shortest duration that you can.
Can you expand that, though? Because I was always under the understanding that because when you look up any antibiotic,
it says take it until the end.
Take it until the end. And many times one regiment will say hit it with 1,000 once and you're done, versus another regiment says take it 3 times a day for 5 days, or another one is 10 days.
Right.
And the mindset I've always been taught is if you don't take it long enough, it'll actually increase resistance because you're just exposing your gut to certain bacteria but not killing off them enough.
Right.
So you said the least amount for the duration needed only.
Yeah.
How do we know what the duration is? And should we be picking the one that's the shortest acting at a dose that's effective?
Yeah.
So I would do the latter, and the how long is enough? Well, that's where clinical science comes in, and strep throat is still 10 days, right, of antibiotics. It seems long, but that's what it takes to sort of decolonize.
But I mean, some of us, for those of us, I was just in a guest speaker in India last year, and came down with a wicked traveler's diarrhea.
Yeah.
And even at that, you read the packages, and one say, here, you take it 3 times a day for 5 days, and there's another one just you load up a big dose once.
Yeah.
Even for your own personal balance that way, is the shorter duration at a higher level a better choice?
I mean, it's tough to know what that looks like.
Each one,
because you end up taking the same amount.
Yep.
Right, and for that specific instance, I wouldn't take the big dose of azithromycin because that will give you diarrhea.
Anyway, it's a fascinating,
Right.
What you learn and appreciate, just the concept of the mutation's already been there, you're predisposing for them, but also, understanding, be as targeted as you can, and as short as you can for the clinical scenario, medically appropriate. It's just helpful to be reminded of that.
I think in the future, you guys have you heard of phage therapy?
No. Phage?
Phage. So this is the idea that these bacteria have enemies too, right? And so it turns out viruses have been targeting bacteria for longer than humans were around. And they're very good at targeting very specific bacteria. And so now there's this emerging thing on phage therapy where, I think in the future will be, if once we have the diagnostics, where this is the bacteria, this is the phage, we'll be using phage therapy a lot more.
That just kills the targets the bacteria.
Yeah, the thing we're doing, right? This is, let's just kill the one bug that we need, and we'll look back and wow, we used to carpet bomb the GI tract and wonder why people had so many problems. Because now we're finding with the microbiome that it's, if you alter the microflora, you lead to all kinds of things. And there's, of course, C. diff is easy, and antibiotic resistance that's very clearly proven, but there's some associations with obesity and depression and all this stuff and allergic diseases. And I wonder just how much of this is being caused, frankly, by antibiotic use. And
I hear about that all the time. Moms talking about antibiotics in kids, and then all these downstream effects because they were on antibiotics so much during childhood. Is that a thing?
I mean, it's hard to prove.
But
I think so.
It makes sense that it could influence things down the road.
And I would love to get away from that.
Absolutely. It makes me think of they have the little aphid that gets on the Japanese beetle that now is killing the Japanese beetle. And you're like, yes. Do you know what I'm talking about?
I do.
For
I
my
do not
garden
like them
lover.
either.
It's so great. No, that's fantastic. Are there big things that you, as an infectious diseases doc, wish that non-ID docs knew?
The first thing is, just understanding the immune system enough, right? This instead of just throwing your hands up, immunocompromised, in what way, to what degree? And if it doesn't work, doing the same thing again or for
Yes.
don't do that.
I love
Right.
that tip. That makes so much. We see people all the time. This is their 10th course of
The same
the
thing.
same thing, and you're like, "What is happening?" Yes.
Yeah, if wishing is just not gonna, it's not gonna work.
If something's not working, though, and oftentimes in ophthalmology we culture
Yeah.
the
Yep.
surface of the eye, or we intraocularly tap vitreous in some way to get tissue. But from a surface perspective, when they've been on an antibiotic, how effective are those cultures? And we hear that they're not going to work, but is it still helpful? Or once you've been on something long enough at a strong enough strength,
Nothing's gonna grow.
does it nothing grow?
So it's not that nothing's going to grow. I think the risk you have, again, this is now the outside of the donut, right? The outside of the eye is still the outside of the donut. If you give an antibiotic, within a day, you're going to have different bugs colonizing the outside of the donut. And so you have to just take very good caution in knowing, is this the real pathogen, or have I just grown new commensals, right? Whereas if it's in the vitreous, that's the inside of the donut, right? And you can very much trust that because
sense.
there should be no bugs in the inside of the donut.
Yeah.
That makes total sense. This is so helpful, and I hope that ophthalmologists out there will be invigorated with a new appreciation for infectious diseases and antibiotic stewardship, all the things. Thank you for educating us.
Perfect. Thank you very much.
Thanks. You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more